Good morning, guys. Welcome to the NEET PG Live Daily once again. And today I will be finishing this topic, hypolipidemic drug, because it took time because I wanted to explain each and everything, and more important was to build up a base how this lipoprotein metabolism occurs, so that you can understand each and every drug, how they can interfere in a particular cholesterol pathway and reduces different species of lipoproteins. So that was important, in fact. And today I have added one more drug. I was just navigating through different literature, so I found one more drug that I have added at the end. That is also important to know, that has been left in the classification, but no problem, you will be given information about that particular drug as well. For those who are appearing on this platform or very new to this platform, they are watching me first time, let me tell you that I am Dr. Pramod Sharma. I am a clinical pharmacologist by super speciality, and I have done my MD and DM from PGI Chandigarh. Guys, this is important, this Telegram app. I keep reminding you about this Telegram app and all, because this is a messenger app just like WhatsApp. All of us probably use it for sharing messages and all that. So you can join this group on this Telegram app. This is NEET PG live group, where actually Unacademy, we guys keep posting our information about our classes, timing, the topic and all that. So that would definitely be useful for you, because you guys are busy in your studies, and you also have your timetable, so you cannot take out time unless until you have a prior information about any particular class which you are interested in and would like to watch, or you have some favorite educator or some topic which you are looking for, that is sometimes you feel that this topic is difficult, let it be explained by someone who is expert in this field. So that way you can always plan your activity accordingly, and that is always good, that if you have information beforehand. You guys are attending this live class on YouTube, that is NEET PG channel, but there is another platform, that is on Unacademy learning app. Unless until you have this app, you will not be able to watch those free classes that are called special classes. So I also teach on these special classes. I will be starting I have started antimicrobial drugs on special classes, so you can watch me over there as well. So accordingly, if you are watching these YouTube classes and you have another facility of watching free classes on this Unacademy learning app, the only difference is that is on YouTube and this is on Unacademy learning app. So first of all, you need to download it and install it on your systems, then only you can join me on special classes. This is also absolutely free, but there is some differences are there, because this class will allow you to interact with your educator. So that is a good thing, that you can interact with your educator. You can raise some query or you can ask some question, interrupting educator in middle of the class. And also if you keep following the educator, you can send direct message to the educator, so that he can directly answer that question on the message itself. So that is one of the very good facility available to you. So you should avail these kind of privileges which have been privileges have been offered to you free of cost. Other than that, there are Unacademy has also another portal that is called Unacademy NEET PG Plus, which is specially for those guys who actually expect more than these free classes, and that is in the form of the special some special facilities that are especially for this kind of individuals, and this particular channel actually caters to need of only these kind of PG aspirants. So that is but available on subscription basis. You are watching these free classes, free courses on YouTube, as well as special classes on Unacademy learning app. And but this plus is available on subscription basis, because premier service always available at a cost. Everything cannot be offered free of cost anyway, because there should be some revenue generation for maintaining the meeting operational cost of all these things. So subscription is available, and subscription is open all the year. You can join anytime when you feel like, and the different duration of subscriptions are available. That is for 24 months and 12 months. It depends upon your need. 24 months will be useful for them who are still in their final year, and but are serious enough to prepare for their PG entrance and all that. Because what happens if you have taken this subscription for 24 months in the final year MBBS, so what happens, this actually makes you well ready for your final exams as well, as well as prepare you for PG entrance also. So this is especially targeted to those population. And also 12 month subscription is there. This much is required. That is why minimum this 12 months is required, because for preparation you have too many subjects. The syllabus is too lengthy, and during this period this much time is needed for you to get get familiar to all the educators from different speciality and all that. And you have at least opportunity to attend all these several special courses which are there on the NEET PG, or which are launched by these educators depending upon the need of the students. And they are also, the courses are customized or based on as per the requirement of different PG entrance examinations. So this 12 month is necessary that way. Otherwise, depending upon your choice, you can go for any duration of subscription. And this is my referral code which you use. If you use, you will get 10% discount on the amount Unacademy is charging for subscription. And for 12 months, this is if you apply 10% discount, this roughly comes to 20,000. And by adding little extra, just 5,000 to this amount, 20,000, you can extend your subscription to 24 months. So this is I think is not a bad bargain. This is very valid and justifiable the amount the Unacademy is asking for. The special this why this NEET PG Plus is special and why it is available on paid basis. The reasons are many, like the live classes which you are attending here is you do not have opportunity to interact with educator. And but in this NEET PG Plus, the number of learners are always less. Excuse me. Always less. And that is why these educators are able to focus on each and every learner, and can address their weaknesses in a much effective way. And because of the less number of the student, the class is more interactive. There is a kind of interaction between the learners and the educators. You have ample opportunities to ask your doubts, your queries, or any explanation about any concept and all these things. You can interrupt the educator in middle of the class and can ask these things, and these things will be answered right then and there. So that is a big point or big advantage to the learners, because if something comes to your mind and that is clarified immediately, that lasts longer in your that is retained for a longer time in your brain. That is actually a proven fact. And Also this if there is an interaction, it's in fact real-time interaction between the educator and the learners, and I suppose I personally feel that this kind of interaction between the learner or educator makes any learning process more healthy and more efficient as well. And other than that, you have facilities for like polls and leaderboard facilities there. These provisions are always useful, and there are available many test series and their analysis. These things are never available free, because more you do, more you learn, more you become confident, more you are prepared for or ready for your entrance examinations, and the probability of scoring better in your exams, that probability goes up, because this is how you build up your base and enhance your knowledge and develop skills of for how to solve questions in different subjects. And as a protocol of NEET PG plus, we need to take this doubt clearing sessions once there are 3 sessions of or 3 classes are taken by a particular educator, and after that there is a doubt clearing session, but there is always an opportunity in the live class itself that you can ask anything whatever you feel like. But this live doubt clearing session, I am not saying that once you have attended the class all your doubts are over. You might come across something new which you feel is not you are not able to understand. That you can always come up with that and ask same thing in the doubt clearing session. So that is how if you have any question and that is being answered in a lucid way and explained in such a manner that you keep that thing always in your in your memory, that goes in your memory and lasts forever. So this is important, because if you have any inquisitiveness, any query, if that is resolved, nothing like that. So this is all about Unacademy subscription. I would definitely request you guys to join this NEET PG plus, and if you like my classes, so I'm there also on the plus as well, so you can attend my courses as well. So that is how your chances of qualify the exam increases many-fold if you have a good learning platform like Unacademy, which is the #1 learning platform in India right now. So let us start with the topic proper. This is the third part of the topic, because this hyperlipidemic drug or hypolipidemic drugs are having number of drugs. Many drugs are available in this group, and this topic is little lengthy, and I wanted to clarify each and everything, because these are the drugs which everybody of us will be using in our clinical practice. So this topic has been covered keeping that in mind. So today is the turn of several other classes of drugs. We have already discussed statins, that is HMG coenzyme A reductase inhibitors. We have discussed fibrates. We have discussed bile acid sequestrants. We have discussed this what we call it nicotinic acid and all that. So today we will be discussing other group of drugs like inhibitor of cholesterol absorption. So till now, until today, there is only one agent available in this group, ezetimibe, and this ezetimibe was actually is a you can say it is a cholesterol absorption inhibitor, and which prevents the absorption of cholesterol from by the enterocytes in the small intestine, and this is actually by this way it reduces total cholesterol as well as the low density lipoprotein as well, LDL cholesterol as well. And how does it act? That is a unique phenomenon. This ezetimibe actually act in the main action is in the jejunum. So whatever luminal or dietary cholesterol is present in the lumen, that is actually its uptake is inhibited by ezetimibe by the jejunal enterocytes. That is, these are these mucous epithelial cells, because these cells has a transport protein, and the HTMI blocks this transport protein that is called NPC1L1, or if you expand it, this is called Niemann-Pick Niemann-Pick C1 like protein 1. So this protein may be involved in Niemann-Pick disease, that is also a clinical entity. And this Niemann-Pick C1 like protein 1 is inhibited, and that leads to reduction of the inhibition of the transport of the or absorption of the cholesterol from the intestine. In humans, it has been observed that this can inhibit cholesterol absorption to the extent of 54%. So this is a very specific number. It should be an approximation. Suppose 50 to 60% cholesterol absorption is inhibited, and not overall. And reduction in cholesterol, I told you during the lipoprotein metabolism when I explaining that diet contains cholesterol, triglycerides, and all that. And this cholesterol is converted into cholesterol esters by the ACAT enzyme, the acyl coenzyme, acyl coenzyme cholesterol style transferase. That ACAT enzyme is important. That is available, ACAT2, available in the liver as well. So this is converted into cholesterol ester, and this triglyceride and cholesterol ester is actually carried out by or transported through chylomicrons. So this when cholesterol is not absorbed, so this is not incorporated into chylomicrons, and chylomicron by the action of LPL, that's it, lipoprotein lipase converted into chylomicron remnants, and when this chylomicron remnants are delivering less cholesterol to hepatocytes. And this is important, in fact, because reduction in the cholesterol in the chylomicrons is important, because chylomicrons is in fact a highly atherogenic protein or lipoprotein. So their concentration, this reduction in cholesterol can reduce atherogenesis. So when there is less delivery of cholesterol by chylomicron remnants to the liver, then liver sense it as deficiency of cholesterol. Then what happens? As a result of that, liver tries to capture more and more LDL from the circulation, and this is possible because I have already told you this SREBP2, that is sterol regulatory element binding protein 2, that actually leads to induction of the LDL receptor gene and increased expression of hepatic LDL receptors. So more and more LDL can be captured from the circulation, and thereby liver compensates for reduced cholesterol, and if there is an increased capture from the peripheral circulation, the serum LDL level falls. But not only that, liver also leads to induction of the enzymes. That induction means increased expression of the enzymes, that is HMG coenzyme reductase for cholesterol synthesis, because liver tends to compensate for this deficiency of cholesterol by increasing the capture of the LDL as well as enhancing the cholesterol synthesis in the liver. So these AGT-MIBs are not very effective agent if used alone, but it can reduce LDL level by 15 to 20%. So its major use is in the combining or in combination with some other agent, so that it can supplement the action of other primary agent. This is the diagrammatic representation. I told you that everything, if explained with diagram, that becomes important. This is a condition when there is low cholesterol, and this is the situation where there is high cholesterol. If there is this protein, this particular transporter, Niemann-Pick C1 like protein 1, C1 like 1 protein, Niemann-Pick C1 like protein 1. So this actually recycles from surface or membrane to this endocytic recycling compartment, that is called ERC. Why? Because it depends upon the condition, whether there is lower cholesterol concentration inside the hepatocytes or there is high cholesterol. So usually what happens when there is increased extracellular cholesterol, that gets entry to membrane. So this is sensed by the this membrane bound this particular transporter. So this actually gets bound to this cholesterol molecules, and binding to cholesterol molecules actually leads to its internalization. And once it is internalized, there is a complex formed by adapter protein 2 and clarithrine. This clarithrine is a very important protein in endocytosis and all that. This is important for movement of any can say any substance within the cell from one to other place, kind of thing. So clarithrine is a protein. So with the adapter this protein 2, this complex actually gets attached to this complex, cholesterol and NPC1L1, and this is in the form of vesicle S along with this microfilament. Microfilaments are important for intracellular migrations of the things and all that. So these vesicles are actually ultimately deposited or stored in endocytic recycling compartment, and this happens when there is high cholesterol. When there is low cholesterol, same endocytic compartment, there is this with this protein actually this it goes to from here this transporter goes back to the membrane, so that it can trap more and more cholesterol from the surface to trap this cholesterol, extra cholesterol. So that is the reason why this actually this protein recycles from membrane to this endocyclic compartment. And how this ezetimibe acts? This ezetimibe actually acts this cholesterol induced internalization and binding to this complex. So this leads to reduction in the absorption of the cholesterol, right? So this is how this ezetimibe acts and its cellular mechanism of action. I don't think there is any difficulty in understanding this, because this diagram is really good. I've added certain things like this, the full form of this, and this ERC, okay, that is fine, that is nothing great, but this is how when there is low cholesterol or high cholesterol, this transport protein actually acts, and this can be intravenous, and it is glucuronide conjugation occurs in the intestinal epithelium. After conjugation, this ezetimibe is actually absorbed, and it is also excreted in the same glucuronide conjugated form. Glucuronide conjugates 70% in the kidney and 70% in the feces, and some amount in the through the urinary route, but all in glucuronide conjugated form. And this cholestyramine or any other bile acid sequestrant, they have tendency to bind to ezetimibe. So ezetimibe will not be absorbed. So one should be very careful. That is why I am saying, if you are using hypolipidemic drug, you should not consider that one drug can be added with another, because they are all can reduce one or the other lipoprotein species. You should be aware of this interaction and all that. That is important. Suppose you add cholestyramine with ezetimibe, cholestyramine can also reduce LDL, and ezetimibe is also reducing LDL, so you thought of adding two to get a synergy or something like that, but actually there is antagonism of both the agent. It does not allow, cholestyramine does not allow ezetimibe to act. There is antagonism of the action of the ezetimibe. So this is important, you should be aware of. So ezetimibe is never given with bile acid or this anionic resins. Okay, it is available in only one strength, 10 milligram tablet, because in clinical studies it was found that in the dose range of 5 to 20 milligram there was no change in its efficacy or further inhibition of the cholesterol absorption from the intestine. That is why only 10 milligram strength is recommended for use, right? And it can be taken any time of the day with or without food. There is no restriction, and it is actually approved for or indicated for certain use, like homozygous familial hypercholesterolemia. This is homozygous form, where both the allele for the LDL receptors are dysfunctional actually. So it is given here in 10 milligram dose because it is one strength that is available with statins, but here special statins only atorva or simvastatin. So it is used with the highest tolerable dose of the atora or simvastatin, because homozygous familial hypercholesterolemia, the effect of because both the alleles of the LDL receptors are dysfunctional, so the LDL receptors are very much they are very or rarely effective, or very small population is effective. So that is why statins can reduce only very little bit of LDL and all that. That is why some other things are also required to enhance the activity of the statins. So although statins are approved for homozygous familial hypercholesterolemia, so adding any other agent may definitely increase the efficacy of statins. Another condition is homozygous cytosterolemia. This cytosterol is this is a phytosterol, means it is a plant derived sterol that is also available in our diet, right? And its structure is very similar to cholesterol. So this can also be responsible for hypercholesteremia in our humans. So this can inhibit this cytosterol absorption also. That is also uptaken by the same transporter. So in adjunct to diet, this ezetimibe can be used only as monotherapy, but dietary control. Maybe certain food products which are, or plant products which are rich in cytosterol, I do not know, maybe some are rich in, so that dietary control may be. Also in primary hyperlipidemia, as I said, it is used in combination with statin, and other than that there is dietary manipulation is also there. So in adjunct to statin plus diet, both are required, and so it can be used in these situations, all three situations. And role of monotherapy, other than that, cytosterolemia, this is rarely used as monotherapy unless there is when there is statin intolerance. That was the case with bile acid sequestrant also. That was the case with this what we call it, nicotinic acid also, so statin intolerance. In that case it can be used as a monotherapy. And both this ezetimibe and statins forms a very synergistic combination, or a rational fixed dose combination, because they complement each other's action. What happens when ezetimibe actually inhibits the absorption of the cholesterol from the intestine, and there is less of cholesterol being delivered to hepatocytes, so liver actually starts increasing cholesterol synthesis by inducing the expression of HMG coenzyme reductase. And when statins are being used, that is actually compensated by body by increasing the enhanced absorption of cholesterol from the diet. I told you this, when the hepatocyte cholesterol level is less, this Niemann-Pick C1 like protein 1 is cycled to or sent to membrane, and so that it can capture more and more cholesterol that is available in the diet and all that. So these two acts together, this ezetimibe, if it increases the expression of the HMG coenzyme reductase, that will be blocked by statins. And statins increases leads to enhanced reabsorption from or absorption from the enhanced absorption of dietary cholesterol from the intestine, that is blocked by ezetimibe. So they form a very rational and synergistic combination. So that is why ezetimibe is available very commonly as a fixed dose combination with statins. And please remember, it's not that even if your dietary cholesterol is 0, suppose you have dietary manipulation in such a way that you take little or zero cholesterol in your zero cholesterol diet, but despite that this ezetimibe is effective, that can reduce LDL levels. And now you will say, how it is possible? It is possible because there is secretion of bile acids in the intestine. So bile acids are what? They are all containing cholesterol. So this ezetimibe may inhibit this reabsorption of the bile acids also. So this will lead to increased excretion of bile acid. So dietary cholesterol, even if it is zero, these drugs, this particular drug has activity in absence of zero cholesterol in the diet, because of increased loss of or enhanced loss of bile acids in the feces. Okay, LDL reduction at the highest simvastatin level. I was telling you that in certain cases, homozygous familial homozygous hypercholesterolemia, it is to be used with highest dose atorvastatin or highest dose simvastatin. So this highest dose simvastatin dose plus ezetimibe actually is similar to high intensity statin therapy. That day I discussed what is low intensity, moderate intensity, high intensity statin therapy. Usually when your goal is to reduce less than 30% of LDL, that is in low intensity. 30 to 50 is moderate intensity, more than 50 is high intensity, and high intensity therapy is usually atorvastatin 80 milligram or 40 milligram of rosuvastatin. So if you are added to high dose of simvastatin with ezetimibe, that becomes equivalent to high intensity in statin therapy. So this is the advantage of adding this ezetimibe to statins. Usually this drug rarely cause allergy reactions. Other than that, there is no specific side effects have been demonstrated or has come to the notice of the users. And very important thing is not a substrate for cytochrome P450 enzyme. That is how it is always good, because such drugs are considered as very ideal drug, because they literally lack drug interactions. But this drug needs to be contraindicated in such a certain situation. As I said, this has very limited role as monotherapy, and it quite commonly available as FDC with statins, and we know statins are not to be used in pregnant and lactating women. So that is the reason all the ezetimibe preparation which are available with FDCs in the form of FDC should not be used. Or if there is hypersensitivity with ezetimibe, should not be used. That is the contraindication. Or active liver disease is important, because these are all conjugation is important for these drugs. So active liver disease or persistently increased transaminases may be unexplained, reason may be unexplained many times. So in these cases, this drug is contraindicated. So these three are important contraindications to use of clinical use of ezetimibe, and one should exercise full caution if already, because it has hepatotoxicity or potential to increase transaminases. So if ALT and AST are remain persistently in over more than or equal to 3 times of the upper limit of normal. Upper limit of normal means, suppose you have usual values 10 to 20. So upper limit of normal is 20. So anything more than 60 will be considered as 60 or more will be considered the upper limit of normal, 3 times or equal to upper limit of normal. So you should be ready to see this, and if there is a sign of active liver disease, because transaminases may be non-specifically may be also increased, because this is the most common sign which is observed during the clinical trials and all that drug clinical trials. These enzymes can increase based on your diet and all that also. So this is the most non-specific finding during the clinical trials. So if it is in presence of this enzyme increase, and there is also clinical evidence of kind of liver dysfunction and all that, then it carries meaning. So then if it is persistently increased more than 3 times, that cannot be because of the chance. So you should be very cautious and correlate it with the liver function as well. If you find something abnormal, then you should be ready to stop the drug. Omega-3 fatty acid ethyl ester. These omega-3 fatty acids these are two omega-3 fatty acids, that is icosapentaenoic acid and icosapentaenoic acid, and one is DHA. You must have seen these ads and all that. I think Bournvita or Horlicks or something contains DHA and all that. So DHA is docosa hexaenoic acid. These are all omega-3 acids. These omega-3 acids, when they are actually acted upon by cyclooxygenase and all that, so different series of prostanoids are formed, 3 series, not PGE2, not like this PGE3 and this thromboxane E3 or like this. So these are the most commonly used fatty acid, omega-3 fatty acid. Actually their ethyl esters are used, and they are available as adjunct to diet, because they all reduce VLDL formation synthesis, and they are used as an adjunct to diet for severe hypertriglyceridemia. So they are actually important in cases where there is raised level of triglyceride, isolated triglyceridemia kind of thing, and oral doses are high, but these compounds are also available as over-the-counter drugs, not drugs, over-the-counter food supplement kind of thing, but they contain low doses, 1 to 1.2 gram, that is 1/4 of this what is available on prescription basis. And these are to be administered with food, because they have kind of some intolerabilities there. So these drugs or these ethyl esters are actually absorbed from the intestine and oxidized in the liver in the same way as there is oxidation of the dietary fatty acids, like beta oxidation of fatty acids and all that happens in the liver. And they have very long half-life, that too is approximately 50 to 80 hours. And if you see that fish oils, because these fatty acids are considered to be present in those fish which are cold water fish, they have high contents like sardine and the salmon. That is why these Eskimos are less likely to have heart attack and all that. So these drugs are considered as good in that sense, because that may reduce atherosclerotic disease and all that. So this omega-3 fatty acid fish oils and the omega-3 fatty acid containing various vitamins, food stuff that are available on the counter are very commonly used world over, and highly sold compound actually, or substances, because of their presence on the availability as over the counter drug. But the concentration is low, but it has been recommended usually to have a good health or to derive benefit of these kind of these omega-3 fatty acids. You should ensure that you take fish in the diet 2 times in a week, variety of fishes, not same fish all the time. And if you actually need this fatty fish oil or these prescription only, this ethyl esters and all that, always consider, or you are thinking of taking these drugs over the counter, ideally you should have consulted your doctor at least once before initiating this kind of therapy. This is how this drug actually act. This is the drug which major action is because of the degradation of this ApoB. This drug, these ethyl esters actually leads to degradation of ApoB, and ApoB, this ApoB is important apolipoprotein for all the triglyceride rich lipoproteins like VLDL, ILDL, this IDL, LDL. So ApoB 100. So whenever VLDL is synthesized, VLDL is what? The cholesterol ester and the triglyceride. But it needs to be attached to this apolipoprotein B, otherwise what will happen? This VLDL will be degraded as well as this ApoB also be degraded. This was the task done by MTP, microsomal triglyceride transfer protein. But here actually this drug is causing degradation of the ApoB, so ApoB is not available. So what will happen? There will be less of synthesis of VLDL plus as well as secretion also, because it is not attached with ApoB, so it will not be carried so there is less secretion, less production also. This is the major reason why there is fall in, because triglyceride level, because VLDL is very rich in triglyceride. Moreover, whatever is secreted is these drug also enhances the activity of lipoprotein lipase, so they will hydrolyze this VLDL, so most of the triglyceride will be broken down into fatty acids, and that will be taken up by the peripheral tissues like cardiac muscles or skeletal muscles, and that way if IDL is formed, IDL is further acted upon by LPL and LDL is formed. So ultimately LDL is derived from VLDL. So if there is low VLDL, so LDL will also be decreased. But in such cases, anything which actually increases decreases triglyceride, that actually increases LDL also, because triglyceride removal maximum, if you remove triglyceride from these, what will happen? Ultimately the LDL molecule will be created, because that contains least of triglycerides. So when there is removal of increases in the activity of LPL and removal of triglyceride from all this, so ultimately there will be LDL rise also. So this is something which is unusual, and further it is also acting by affecting this enzyme diacylglycerol acyl transferase, this which is important in the synthesis of fatty acid to triglyceride. So this triglyceride synthesis is also affected. Not only that, it promotes beta oxidation of whatever is fatty acids are available, so that leads to decreases the availability for hepatic lipogenesis. So these beta fatty acids are actually metabolized, oxidation occurs. And also there is these drugs, these VLDS which has high TG and ApoC3. I told you this ApoC3 is a protein which interferes or delays the hydrolysis or breakdown of clearance of triglyceride rich proteins. So this decrease because of all this, actually there is decrease in ApoC3 and TG content, and that ultimately leads to less atherogenesis and more faster clearance of this drug. So major mechanism of action is degradation of ApoB, DGAT, action on DGAT, action on LPL, and this increased beta oxidation of fatty acids. So all this in unison cause decrease in triglyceride levels, but most common action is this degradation of ApoB. So in hypertriglyceridemia, this is used as adjunct in patient with TGs. This adjunct to diet in patients with this as patients should be here with triglycerides more than 500. It should be this baseline. This actually threshold is used, cutoff value, and it can reduce triglyceride up to 30%, and they are usually used in combination EPA and DHA as ethyl esters, but can reduce up to triglyceride up to 30%. And they also, one indication is there that if there is omega-3 fatty acid deficiency, I don't know how it can be identified, or whether there is any. We specifically go for omega-3 fatty acid level in the blood, I don't know, but in CV patients, this usually those with cardiovascular disease patients, both are used in case of this omega-3 demonstrable or documented omega-3 fatty acid deficiency. But this is always recommended whenever you initiate these drugs, actually, because they are prescription based drugs. So first address all modifiable secondary causes of hypertriglyceridemia. So most common cause of hypertriglyceridemia is modifiable cause. I am talking about uncontrolled diabetes. You will see if those who have uncontrolled diabetes will have very raised triglyceride. Uncontrolled diabetes. Alcoholism, this alcoholic people, these are the means. This raised triglyceride is the most common dyslipidemia observed in this class population. Therefore, then only we should initiate and can derive maximum benefit of these omega-3 fatty acid ethyl esters. And some authorities advocate that they should be used only when the triglyceride level is more than 1000 milligram per deciliter. Then only there is increased risk of pancreatitis and all that. because, and in a very landmark trial study was done to see whether these agents, if added to background statin therapy, can reduce or can lead to further reduction in the atherosclerotic cardiovascular disease. But to surprise, they could not decrease or lead to further reduction in this risk of atherosclerotic cardiovascular disease over and above statin monotherapy. So this was a kind of setback to us, all of us, in fact. And the side effects are nausea, because these fish oils are really this smell bad. There could be fishy burps, this dyspepsia it can lead to because this oil, and this is important. There could be significant rise in LDL. They can reduce triglyceride by more than 30%, but it can increase significantly LDL if both are used. Usually both are used in together, but it has been seen that when EPA is alone used, the rise in LDL is not very significant, and but the triglyceride control is okay, fine. That goes actually does similar reduction or equivalent reduction of triglycerides, but risk of this increase in LDL is less with EPA alone. These compounds may also prolong bleeding time in the patients. So those who are receiving anticoagulant therapy, the monitoring should be, one should be more vigilant about this episodes of bleeding and all that. PCSK9 inhibitors. These are also a relatively new drug. The PCSK is proprotein convertase subtilisin caxin 9. This is an enzyme actually which belongs to this proprotein convertase group, and 9 is the ninth member of this proprotein convertase enzyme family, right? And this enzyme selectively binds to the LDL receptors present on the surface of the hepatocytes and leads to their lysosomal degradation, and thus will reduce the number of LDL receptors, functional LDL receptors on the hepatocyte membrane. So it was considered as a good target for this hypolipidemic drug, because it was reducing overall activity of other drugs, for example this statins and all that, because statin tries to increase the LDL receptor population on the hepatocyte surface, but this at the same time this in gene is also overexpressed, and enzyme led to the degradation of this receptor population also. So the PCSK9 inhibitors came into picture, and they were developed, and they are available as monoclonal antibody. These are highly immunized, fully humanized, or you can say human monoclonal antibody, alirocumab and evolocumab. This monoclonal antibodies actually binds with this free PCSK and interferes its binding with the LDL receptors. Thereby they actually prevents degradation of LDL receptor on the hepatocyte surface. Got my point? Because these are protein drugs, they are to be administered parenterally, and they are administered as subcutaneously every 2 to 4 weeks. 2 or 4 weeks. There are two different dosing regimen, and this actually depends on the the dose which you are using or the indication for which you are using. Half-life is usually 11 to 20 days. So once it is given, they are active for almost 3 weeks, after which LDL concentration starts increasing. They can suppress LDL levels for 3 weeks almost, and after that starts increasing. And metabolism depends upon the concentration or the doses. If you use low dose, at low doses, what happens that all binds to this enzyme PCSK9 K9. So the low doses actually is saturable process, so it binds to this in low doses, and this actually is degraded or metabolized by receptor mediated metabolism, or taken in and metabolized. And another is unsaturable, that is proteolytic. When doses are high, this is a more higher capacity unsaturable process where the proteolytic degradation of this particular monoclonal antibody occurs. So it is a peptide ultimately, right? So the agent evolocumab is approved for primary hyperlipidemia, can be used alone or adjunct to diet or other lipid lowering therapies in adult patients, including those with heterozygous familial hypercholesteremia, to reduce LDL. Also, it is used to prevent CV events, cardiovascular events like MI, stroke, coronary revascularization and all that. You can see this is used for primary prevention kind of thing. This is the picture how these drugs actually act. You see this statins actually inhibit this HMG coenzyme A reductase, so less of cholesterol is synthesized, right? And if less of cholesterol is synthesized, that leads to increase these receptors to be produced on or reach to this surface of the surface of the hepatocytes. So more and more receptor will reach there, and when there is cholesterol is high, then that will not allow these receptors to go to surface, because then there is no need to express more and more receptor to be allocated to the membrane. But when this statin actually inhibit cholesterol precursor, then more and more these receptors are there on the surface, and they capture this is B100 bound, and this is very low triglyceride. So this is LDL molecule. You can see VLDL has very much triglyceride, but this LDL has more of cholesterol esters. So usually what happened earlier, when there was with statin, there is increase in the expression of LDL receptor on the surface, but along with that there was also increase in the expression of this enzyme. So that used to actually degrade these receptors, like in the inside the cell after endocytosis and all that. But once there are inhibitor of this monoclonal antibody has been prepared, this monoclonal antibodies actually binds this PCSK9, because this is circulating free, and this does not allow to attack these receptors, and does not allow the degradation of this LDL receptors. So now LDL receptors are fine, and actually there is they are supplementing each other's action, because there is increase in expression as well as decrease in catabolism by PCSK9. So both if are added, we can expect that there will be synergy. So this picture is very good diagram that is able to capable of explaining everything. See, once triglyceride is formed, unless until it is attached to B100, it will not be secreted. So they see both B100 is attached to that, and then VLDL is secreted by the liver. For both those conditions, this prevention of CV events and primary hyperlipidemia and all that, the dose is 140 milligram every 2 weeks subcutaneously, or you can give once monthly. I told you that the dosing depends upon the indication and means frequency of dosing depends on the indication and the dose. And in homozygous familial hypercholesteremia, you give 400 milligram. The dose is and given only once monthly, right? And alirocumab, you can see primary hyperlipidemia, including just like that, prevention of CV events just like that, but this has changed. There it was revascularization, here unstable angina requiring hospitalization with established CAD. And for both the treatment, doses either around, if 2 weekly you give first 75 milligram, then can increase to 150 milligram, and every 2 weeks, if it is tolerated, can be increased to 150 milligram, or if you want to give once monthly, 300 milligram is the dose as well. Here for homozygous familial hypercholesterolemia, it has orphan indication, not as routine like this here in the case of evolocumab. I already told you that effects are complementary to each other, like statins and these. Statins actually reduces cholesterol synthesis, and also because of that, the liver actually tends to increase the production of the LDL receptor, and their positioning on the surface, so that more and more LDL can be trapped from the circulation. So these LDL receptors were actually used to be degraded by this PCS9 enzyme. So if it is inhibited, so that will further more and more trapping from the circulation because of the presence of functional receptors, and also the reduced synthesis by the statins. So this is both are complementary to each other. These drugs reduce LDC in a dose-dependent manner. It has been seen that if you use alone this PCS9K inhibitor, they can reduce LDL by 70%, and when they are used with statins, the reduction may be 60%. So this is quite surprising, but yes, in monotherapy, but they are rarely used in monotherapy because we have many other therapy available, and they are costly as well, so they are rarely used in monotherapy. But this data is available. Why? Because they have been tried in clinical trials and all that. But something called cost effectiveness and all that is also important. So this kind of restriction can be put on such drugs, that they should not be used in monotherapy, because otherwise the prescriber will start misusing them. They will prescribe it to their patients, because they will get more and more many a times kind of companies promote these kind of products, so unnecessarily there will be a financial burden on the patient. It is prudent to measure LDL-C level once you initiated the dose after 4 to 8 weeks, or any time when you actually change the dose. If you increase the dose, then after 4 to 8 weeks you measure the LDL-C level, and if you initiate the therapy, then only after 4 to 8 weeks check whether how much is decrease in the renal or hepatic impairment data is not available, but this has been expected. That is unlikely to affect the elimination of the drug. Unlikely to affect, but no adequate data is available in case of renal or hepatic impairment. And this drug should not be used in pregnancy, because it is expected that it might get transmitted across the placental barrier. This is such a data is also lacking. And moreover, it is also not clear whether to what degree this drug will be available in the or secreted in the milk and all that. So it is also recommended that it should not be used by lactating women. And this drug is, first of all, is to be given parenterally. That is an important thing. That is a problem subcutaneously, and this and this is actually requires storage, certain storage condition. This is to be stored under 25 degrees Celsius. If you do not have refrigeration facility, can be stored under 25 degrees Celsius for 30 days. And if you keep without refrigeration under 25 degrees for 30 days, if it is not utilized, it should be thrown away. Moreover, this drug is light sensitive also, so it is to be kept in its original carton. It should not be taken out of that. It should be stored in that only. And those who have refrigeration facility, it is to be kept in not in the freezer compartment, but in normal compartment. And once you take it out, it should be allowed to come to the room temperature. So it's to be kept outside for 30-40 minutes, and then only inject it. And it can be injected on thighs, abdomen, as well as upper arm. So these are all this important thing, and the cost, these things are actually barrier to its popularity. Cost is too much. That is why it is only recommended when a patient has already given trial of ezetimibe and maximum tolerable dose of statin. If that is not capable of attaining target LDLC level and all that, and further reduction is required, then only these to be used. This is the indication. Otherwise, what will happen? The people will start using it. Doctors will start prescribing it for as monotherapy and all that. Most common side effect, as we expect that we are giving it, subcutaneous injections. So injection site reactions are common. Maybe 10% of the people experience this kind of site reaction. And there is data coming up from several clinical studies, and these data have shown that there is a risk of neurocognitive decline. That it has effect on neurocognitive functions. But now larger trials are being tried, and long-term effect on this neurocognition is being tested. So with time, that data will also be available. So for the time being, this is important. It has though small, but risk of neurocognitive effect is definitely there till now, as data has revealed from the different clinical trials. Myalgia can occur, but unlike other drugs, which many of the drugs like nicotinic acid, gemfibrozil, and cyclosporins and all that, many drugs which inhibited CYP3/4A also inhibitors also, if they were combined with statins, the risk of myopathy was increased substantially. But in case of this is unlikely, and this risk is very minimal if at all is there. But myalgia can occur, and as like other monoclonal antibodies, the risk of infection is also a little bit increased in these patients, including nasopharyngitis, urinary tract infections, upper respiratory tract infections, because these biological agents are usually associated with an increase in risk of infection and all that. But this drug, as I told you, they undergo proteolytic degradation, especially this alirocumab. Evolocumab, as I said, this at low doses, it is receptor mediated, binds to PCSK9, and it is taken up by receptor induced cytosis and degraded. But at high doses, which is the proteolytic pathways, which actually leads to damage. And alirocumab, the exact information is not available, but being it is a protein, it is expected that it is broken down into smaller peptide and amino acids, ultimately amino acids. So that is the way how alirocumab is metabolized. And they do not interact with CYP enzymes and all that, so they are not at all, one should not bother about any kind of drug-drug interactions, especially those actually when the drug is a substrate for CYP enzymes, then there is always possibility of drug-drug interaction. This is another class of hypolipidemic drug, that is inhibitor of microsomal triglyceride transfer protein. I told you this my MTP, role of MTP, microsomal triglyceride transfer protein. It is present in the intestine as well as in the liver, and it is a very important protein. What happens when we take triglyceride in our diet, all our oils and whatever meat and everything, that all contains triglyceride, and triglyceride cannot be absorbed like this. It has to be first connected to its apoprotein like B48. Whatever is absorbed from the intestine, that is attached with B48. So then it is incorporated into chylomicrons. But triglyceride otherwise elsewhere, VLDL, LDL, IDL, there is B100 in the liver. It is attached to B100, that is apolipoprotein. So this macrosomal is important. Endoplasmic reticulum, it is present. So the dietary triglyceride, first it is to be attached by this MTP. This MTP, the protein actually plays the role of attaching this triglyceride to B48. So this lomitapide is the drug which is actually, it directly binds to and inhibit this MTP, which is very important for the formation of VLDL by the liver. But in the intestine it is also important, because chylomicron will not be or triglycerides will not be absorbed. So at both the places it is present, and if it is absent, what will happen? This apoprotein will also be degraded, and the VLDL synthesis will not occur. This drug has an issue that it is to be administered with water, sufficient water, and without food. So usually given at night after the evening meal, 2 hours after evening meal. So that is equal to similar to without food you are administering, because it is considered that it can reduce, giving this in this manner and administering in this manner will reduce the GI side effects, which are quite significant with this particular drug. And this has, you can see, has a poor bioavailability, and that is not a concern, because it actually ultimately is used clinically, metabolized by CYP3A4. This is important. Half-life is 40 hours, not a problem. So it has been used for homozygous familial hypercholesterolemia. So this is used as an adjunct to diet, because this condition is such that we have to use all possible ways to bring down this cholesterol level down. So in adjunct to diet should be also poor in cholesterol and all that. Other than the other lipid lowering therapy should also that can reduce LDLC, total cholesterol, ApoB, and non-HDLC, all this, and then this is to be added. Means this condition is such that it requires multimodal approach. Means you can use combination of 2 or more drugs. Doses are usually 5 milligram per oral, as I said, after evening meal, 2 hours after meal. And if you start with 5 milligram, after 2 weeks you can increase it to 10 milligram. If it is well tolerated, then after 4 weeks you can go to 20 milligram. And if it is also vitally tolerated, then after 4 weeks you can go to 40 milligram. And if it is also tolerated, after 4 weeks you can go to 60 milligram. This is the maximum dose which is recommended. It should not exceed 60 milligram a day, and it can reduce LDL by up to 50%. You can see. So this is important in homozygous familial hypercholesterolemia. So this is a kind of ray of hope for these individuals which were not adequately controlled with statins and all that. So this is important. See, this is the normal mechanism where what MTP does. This endoplasmic reticulum, because it is microsomal, so that is present in the endoplasmic reticulum. So this is ApoB, this is cholesterol ester and triglyceride. They are all mixed, and because VLDL contains also cholesterol ester and triglyceride, but TG is more than cholesterol ester. Same in chylomicron, TG is more than cholesterol ester. Here the ratio is 10:1. Here the ratio is 5:1. So this is in presence of this ApoB, this MTP ultimately leads to this production. But once MTP is blocked by lomitapide, and this ApoB anything can be B48 this is used in enterocytes, and this B100 is used in hepatocytes. So what happens? This actually cannot be, VLDL and chylomicron cannot be. These are all, you can see the broken line. These are all broken line. It means innovation is there, so they prevent production of chylomicron as well as VLDL. So there is decrease in the, ultimately LDL decrease will be there, because whatever LDL is present in the blood, for all practical purposes you should remember this, just mug it up, that all LDL is, whatever is circulating in the blood has come from the VLDL, right? And VLDL is produced from the liver. Significant diarrhea, significant. I'm telling you, that is why I told you that special administration was required, that after evening meal with water and with empty stomach, means without food and all that. So this can be, this is very high, and but people suggest, and it has been suggested, that strict low fat diet may improve a little bit tolerability, this GI tolerability may reduce these kind of side. But more serious concern is about hepatotoxicity. Almost 1/3 of the patients from clinical trial have shown increase in the transaminases. But as told you, this rise in transaminases is very non-specific finding, and this is the most important clinical parameter that is found abnormal in case of in any clinical trial with any drug. This is usually the most common abnormal clinical laboratory finding, right? So, and other than that, liver steatosis is also an issue because it can lead to increase in hepatic fat. So steatosis can occur despite without increasing transaminases, so that should also be considered. And this drug can be embryotoxic because it is can be embryotoxic, and because no established safety in the pregnancy is available, so that is why it should be used only if in women of childbearing potential, if she is using effective contraception. And something this term is called as risk evaluation and mitigation strategy. Actually, many drugs which have clinically important but have associated safety concern as well. In such cases, US licensing authorities they approve those drugs, but they put certain restrictions. They keep a check on it is the sponsored or manufacturer or the inventor of that particular drug, or the company which has launched that drug is strictly asked to keep record of each and every prescription and its safety, what happens to those patients and all that. So this is called risk evaluation and mitigation strategies that help licensing authority to have data of all the subjects being treated with this drug and decide how much is the risk that can be better evaluated when it is used in larger population, and how it can be mitigated. This kind of, so many drugs are under this program. They cannot be used without monitoring. So they are to be monitored seriously in case of they have been labeled or put under the AIIMS program. So this is one drug which is put under the AIIMS program. This is yet another class of hyperlipidemic drug or a hypolipidemic drug, that is called inhibitor of ApoB100 synthesis. This ApoB100 is very important for all triglyceride rich or beta lipoproteins like VLDL, LDL, IDL, etc. So mipomycin is an antisense oligonucleotide. It is an antisense oligonucleotide. This is actually nothing. Oligonucleotides are what antisense. These are single-stranded DNA kind of thing. And this antisense oligonucleotide inhibitor, this actually selectively binds to binds to the messenger RNA in sequence-specific manners, and it leads to, because this is single-stranded DNA kind of thing, oligonucleotide, that actually messenger RNA leads to translation of certain proteins. So it actually binds with messenger RNA and will degrade or disrupt the this messenger RNA, or will interfere with the translation of the protein from this specific messenger RNA, and thus synthesis of the ApoB100 will be reduced. And if ApoB is not there, then VLDL and all that not be synthesized or will not be secreted by the liver and all that. And this drug, it is a oligonucleotide. It is actually metabolized in the tissue by endonucleases, because it is nucleotide kind of thing. So endonucleases to further smaller oligonucleotide that is further degraded by exonucleases. So these are responsible for metabolism of this antisense oligonucleotide. There is also oligonucleotide inhibitors. They act through RNA interference. They do RNA interference, not actually degradation of messenger RNA and all that, but which happens in case of antisense. They inhibit actually translation of protein from the transcribed messenger RNA. T half is 1 to 2 months. Very good. And maximum, but here the effect of reduction in the LDL can be observed only after 6 months sufficient, or maximal effect is observed after 6 months of therapy. And level can be reduced by 32%, 30 to 50%, not bad. It is also very good. That is why this drug is also, this is the mechanism of action which I can show you. So, from DNA, there occurs transcription of, messenger RNA. And this messenger RNA ultimately leads to, this messenger RNA ultimately leads to translation of protein depending upon the information encoded in this particular portion. So this is ApoB messenger RNA for ApoB prosynthesis. So this is the antisense strand, single strand. So this binds with this, hybridization occurs, and this binding leads to activation of RNase H. That actually leads to breakdown of the degradation of this complex. And you can see these are broken down, this messenger RNA which was ApoB messenger. So there will be no translation of the ApoB. So if there is no ApoB, there is decrease VLDL. So this decrease VLDL, there will be decrease in all ApoB containing lipoproteins. So that will ultimately lead to decrease LDLC. Not only these antisense nucleotide can also affect or lead to steric hindrance in the ribosomal RNA function. Ribosomes action also, steric hindrance, that is just because of the volume. This is non-binding interference. They need not bind, but because of its voluminous, because of the volume, it can interfere with the ribosome function also. This is also, as I said, this is also indicated for this homozygous family hypercholesterolemia, because this was the general defect that was difficult to treat. In similar as an adjunct to other therapies and diet, other lipid lowering therapies and diet to reduce LDLC, ApoB, total cholesterol, and non-HDLC. Right? So the total dose that is given is 1 ml subcutaneously once weekly. Because 1 ml it is available as 200 mg per ml strength, so 1 ml is to be administered. And very common is injection site reactions. More than 80% individual have shown, and that can appear as the pain, erythema, tenderness, itching, and also the local swelling can appear like this. So it is very common. You can see more than 80% individuals. Other than that, there could be flu-like symptoms, fatigue, headache, and more serious is the hepatotoxicity. So it has a black box warning attached with it. What does it mean? If a black box warning is attached to a particular drug, it's life is compromised. Its total life is shortened actually. So that is why it is recommended that you do all LFTs, baseline LFT, that is transaminases, bilirubin, alkaline phosphatase, and thereafter also regularly keep repeating. And it is contraindicated in individuals who have either moderate to severe hepatotoxicity or hypersensitivity to this drug. So moderate to severe hepatotoxicity means child poop classification B and C. So in those individuals it is contraindicated, should not be used. And this baseline LFT is important. You keep so usually if you have started this drug and a patient has you start monitoring and you find that transaminases are more than 3 times of the upper limit of normal, but less than 5 times of the upper limit of normal. Then in that case you wait for 1 week and again repeat the test, and if you find the same, withhold the drug. Or if whenever you do LFT, though if you have any doubt of hepatotoxicity, you can always do LFT. But as a routine monitoring, if you find there's transaminases more than 5 times, upper limit of normal, you should withhold the drug. This is the practice one should adopt. I was talking about this drug. This was actually another drug which is available for hypolipidemic, as a hypolipidemic drug which can reduce LDL-C level. It is bempedoic acid. This is this particular enzyme inhibitor, ACL inhibitor, adenosine triphosphate citrate lyase inhibitor. This is an enzyme which is present upstream in the synthesis of cholesterol. Like in cholesterol synthesis, we had HMG coenzyme reductase, that was second enzyme, rate limiting enzyme. So similarly, when you go ahead, there is another enzyme, ATP citrate lyase. So this is actually, this is its active metabolite, this bempedoic acid, as well as its active metabolite. It has an active metabolite. Both needs to be activated, and that for that it requires something called acyl coenzyme synthase, very long chain acyl coenzyme synthase. So this is called ACSVL1. And one important thing is this is primarily expressed in liver only. So it has effect in liver, where actually cholesterol synthesis affect cholesterol synthesis in liver. So it is to be used as an adjunct to diet and maximally tolerated statin in adult, including this is inclusive of maybe other having this high cholesterol level and all that, including adults with heterozygous familial hypercholesterolemia, or also to reduce atherosclerotic cardiovascular risk who require additional LDL-C lowering effect. If you think that these particular individual can require, so same thing, it is to be used in combination adjunct to diet and maximum tolerated statins in adults with including this and this. These are the two indications for this particular bempedoic acid. And it is available usually in combination with ezetimibe, and this is the dose, 180 milligram of bempedoic acid and 10 milligram. This is available only in one strength, is to be given. However, the adverse effect very unique is tendon rupture. Usually this tendon rupture can involve the rotator cuff tendons, also the Achilles tendon or bicep tendons. Other than that, muscle spasm, diarrhea is common, and this bempedoic acid, actually you can add it to your notes that this is yet another drug which is available for and can be kept under the group ACL inhibitor, ATP citrate lyase inhibitors. So this is all about today's class, but this is the grammatical representation. I told you that as you can remember things better if there is this is supplemented with diagrammatic information. C is bempedoic acid inhibiting ATP citrate lyase, which comes from the TCA cycle through citrate, and this. So this acetyl coenzyme A, HMG coenzyme A, coenzyme reductase and all that. So this is actually can lead to inhibition of cholesterol synthesis. So can lead to reduction in LDL level. This is the overall summary what I have taught till today in this chapter. This I have added because this was not there in this diagram. So this ACL is there, and see anion exchange resins, they inhibited bile acids and all that, and ezetimibe inhibiting actually this cytosterol or cholesterol in the diet. So all these things, and mipomycin is actually degrading B100 synthesis, so there will be no secretion of VLDL. See this blue lines, VLDL secretion will not be there. Even lomitapide can act on here. There is no triglyceride absorption here, and as well as there is no triglyceride synthesis in the in the intestine also, liver also, so reduced VLDL release. Niacin can act on lipoprotein lipase. HDL increase was also there, and also the VLDL release was reduced. Fibrate actually was reducing VLDL and lipoprotein lipase. They are acting. PCSK9 inhibitors are acting on LDL receptors. Statins also acting on LDL receptors, increasing LDL receptors. And statins was also inhibiting HMG coenzyme reductase as well. So all drugs are almost used, but only thing I think that ethyl esters, they have been missed. But this diagram gives you an overall picture how these drugs are, where exactly the site of action of these drugs, right? So guys, once again I am reminding you the importance of this messenger app, that is Telegram app. You should all have this Telegram app and join this group, and so that you have beforehand information or well in advance, so that you can spare your valuable time to watch any session of your interest, or any the educator which you actually like most. You do not want to miss any classes of those educators. So this is important because you keep receiving information about those things. And one good thing is that once you click this link, it can take you directly to the YouTube NEET PG live daily channel, so you can watch there this topic of your interest or educator of your favorite educator. I again reminding you that if you do not have this Unacademy learning app, you please download it, because this app will give you another platform to watch things or learn things without any without paying a single penny. That is in the form of special classes. Special classes, you have additional benefit in the form of that you have opportunity to interact with educator. Not only that, this interface of this particular platform is absolutely different, and it gives you a feeling about little bit about NEET PG Plus platform. You will understand that if you shift to NEET PG Plus, how it will look like. That from the quality of this special classes platform, you can understand. And another advantage of this Unacademy learning app, that if you follow the educator, what will happen, that you can send him or her direct messages related to any query from the any lessons, whatever you feel like, and that would be answered by that educator. So you are getting free of cost these kind of premium services. So why not? You should have this learning app. Not only you, your friends of friends, everybody should have it. Everyone should have it. Everyone means those who are having from the medical field, and those who are not those do want actually looking for something extra, and not only they are happy with this free classes, but they want something extra as well. For those, Unacademy has another platform that is called NEET PG Plus, which is specifically created for such aspirants who actually looking for something extra, and some other more features, more facilities, and for them this plus is the right choice. But this is available on subscription basis. This is not free. Every premium thing is available at a cost. Everything cannot be made free. If it is made free, it will lose its value. The subscription is available for 12 months and 24 months. As I already told you, that 12 to 24 months is good for those who are preparing right from their final year, because this will not only help them do better in their final MBBS exams, but also at the same time they will have parallel preparation of the first PG exam they will face. So this is good for them, and this is available for very less amount. Whatever you pay for 12 months, you just add little extra, you can increase this to 24 months. And 12 months is also okay, but this much time is required, because you need to get familiar with all the educators and their way of teaching, and the style and their knowledge, and they, all these things are good qualities. Not only the knowledge matters here, the other qualities you can also imbibe from these educators that will help you become a better doctor in future. And also these educators will keep floating their special courses on this platform, and as many as you attend, you will definitely be benefited in terms of scoring higher marks in your PG entrance and all that. And if you score more, what does that mean? Scoring more is more chances of selection, better chances of selection, better college you will be getting. You might get your subject of your choice and all that. So for 12 months the subscription, if you apply my code, this Dr. Pramod, you will get 10% discount. So this will be roughly around 20,000 rupees. And if you are interested, belong to that category which will be benefited by 24-month subscription, by adding little extras, that 24-month subscription is available hardly for 25,000 rupees. So I don't think that is a bad bargain. This is reasonable considering the the facilities being offered to you by the Unacademy. Although the Unacademy has made a majority of the things free of cost to the learners, so that more and more students are benefited by this particular learning platform. And this is a kind of democratization, or you can say social service. So I really appreciate this noble step taken by the NEET PG, this Unacademy, which is considered as the best learning platform right now in this country. And you should not stay away from this. And if you have decided, and if you think of joining in future also, don't forget to apply this my code. The subscription is open 24/7 the entire year, so you can join whenever you feel like. And yes, use my referral code and get 10% discount. Anyways, these are the benefits which you should expect from an Unacademy subscription. That is why it is available on paid basis, because all these things which you will not find anywhere else, these are exclusively present on this platform. That is why you need to pay for it. And that is also not too much for making you ready for your PG entrance examination, and increasing your probability of cracking the exam. That amount is reasonable, I think. And this is one-stop solution for all your needs. And this NEET PG Plus understands better what learners actually looking for. So this has scope of lot of customization based on your need and all that. So you should be there on this platform. This much I can suggest or recommend, rest is up to you. But anyways, you keep attending this NEET PG live daily, and if you have liked my lecture, give me a thumbs up, so that I feel also little you can say enthusiastic or overwhelmed. And share this link or share this lecture with others also, and ask others to subscribe as well, so that this information or this benefit everybody should be able to use or take these free classes. So with this, I think we have successfully completed this hypolipidemic drug. And don't ask me in future that I have covered each and everything, and you will remember this. Whenever you feel any problem, you can always drop me a message, or you can just go through these lectures. I tell you, you will be not having any problem anywhere. And do one thing, you start specifically question from this particular topic, you start solving after reading this. You just see how many questions you are able to solve. I think there will be no question which you will not be able to solve. So with this hope, I say goodbye and good night to all of you. Thank you for attending the class. Bye-bye.